So good afternoon, everyone, and welcome to this session. Can we kindly assume our seats? My understanding is that there are quite a number of people online following this very eagerly. Though we have very few in the room, I can guarantee you it is not um, a reflection of the level of interest in this. At least from a personal perspective, I have a lot of people who have reached out to me saying they are waiting eagerly for this. On LinkedIn and on other forums, I know that people are very eager for this. So to those of you who are following online, a very warm welcome to you. Um, we just had our lunch, and we also hope wherever you are, you've had something to eat and are not hypoglycemic. Um, so what I'm going to do is to just call my panelists to just join me um, on the on the days. I'll just call them one after the other, and then I will ask them to introduce themselves. In fact, I'm going to do this. I will call them after themselves, one after the other. They'll introduce themselves, and then I'll call the next person, and in that order, so that they can have the stage themselves. So this session, and I'll give a better introduction to it, is focusing, or this workshop, I'll call it that, is focusing on One Health and the pandemic treaty. It is a very touchy subject in many ways, and if you're not aware why it is a touchy subject, I know some of us are very much in love with One Health and in love with the pandemic treaty and are very militant about how things should be. But ultimately, this activity rests within various frameworks and various bodies. And so it's important that we understand how this ought to be navigated, not that there are many other options, and to really do the best that we can with the tools that we have available. So we're going to be examining One Health and the Pandemic Treaty. And I will give a better introduction to the subject matter at hand, but I want to start, first of all, by welcoming Germain Velasquez from the South Center. Round of applause for him, Germain Velasquez. So if you can please choose the seat of your preference and kindly introduce yourself, tell us about your center and yourself and what you do, and then I will call the next person. Over to you, sir.
Bonjour, je vais, on est à Sénégal, donc je vais parler en français.
Oui, ça va, tu veux parler en français.
J'ai massacré la langue française un petit peu. Et je m'appelle Germain Velasquez, je travaille au South Center, c'est un organisme intergouvernemental qui est basé à Genève, où il y a 55 pays membres, entre autres la Chine, le Brésil, l'Argentine, l'Afrique du Sud. Et nous suivons les négociations qui ont lieu à Genève. C'est pour ça que le centre-sud, il est au nord, il est basé à Genève, parce qu'il s'agit d'assister les missions permanentes à Genève, des négociations, pour les négociations qui ont lieu à Genève. J'ai passé une vingtaine d'années à la OMS, et j'ai eu la chance, ou le malheur plutôt, de commencer le travail en propriété intellectuelle à la OMS il y a une vingtaine d'années. Et j'ai dit la chance ou le malheur parce que ça m'a créé beaucoup de problèmes, même personnels. On était un groupe qui a commencé tous les débats en propriété intellectuelle, et brevets et accès aux médicaments. Un tout petit groupe, parce que le groupe, c'était moi-même et un juriste qui m'assistait pour les questions juridiques. À l'époque, la OMS était complètement incompétent dans le domaine des propriétés intellectuelles. C'était juste au moment de la création de la OMC. Donc, je vais essayer de commencer les sujets me posé une question hier. Un des participants online, il a posé la question aux panélistes. Il a dit quelle est la différence entre santé mondiale et une santé durable. Moi, j'ai trouvé très intéressant la question, mais un des panélistes, une des panélistes a été un peu trop brusque, je dirais, à mon avis. Et elle a dit non, il a rien à voir. Ce sont deux concepts totalement différents. Et une des raisons qu'elle a données pour dire que c'était différent, il a dit les One Health, une santé durable, il y a l'engagement de la communauté. Et la communauté doit participer. En plus, la santé mondiale, c'était un concept qui était très centré sur l'accès aux médicaments, l'accès aux diagnostics, etc. Les One Health, c'est différent. Il y a donc l'engagement de la communauté. Et là, ça me fait penser à Almata. Donc, santé pour tous. On ne peut pas dire qu'à l'époque des soins de santé primaire, quand le concept d'Almata a été lancé par le directeur général de la OMS et UNICEF, les communautés s'étaient très, très engagées. On parlait de l'accès à l'eau potable, on parlait de nutrition, etc. Il n'y avait même pas de médecins. On parlait à l'époque des médecins au pied nu. Donc, je me disais, il y a ces trois concepts. Et en plus, il y a le directeur général de la OMS qui est pour la première fois après 75 ans en africain, le docteur Tedros. Depuis qu'il est arrivé, il nous parle de couverture sanitaire universelle. Donc, il y a un quatrième concept. Et quelle est la différence entre santé globale, quelle est la différence entre une seule santé, la couverture sanitaire ou tout simplement l'accès pour tous des malades de la conférence d'Almata. Je crois qu'il y a un commun dénominateur aux quatre concepts et qui cause, à mon avis, un problème. Et le problème, c'est que ce sont tous des concepts qui assument que les actions vont être à caractère volontaire. Donc, il a rien d'obligatoire dans les quatre conceptions. Il n'y avait pas Almata et la santé pour tous, il n'y avait pas une conception d'obligation. Il n'y a pas non plus dans la santé mondiale. Il n'y a pas, jusqu'à ce que j'ai entendu hier et ce matin, dans une santé durable, c'est plutôt volontaire. Et dans le concept d'une santé globale, dans le contexte du traité international, qui c'est le sujet de ce panel, je vois encore un problème supplémentaire. C'est que la mise en œuvre de une santé durable se fait à travers des plateformes où il y a un partenariat privé-public. Et la question qui se pose, c'est qui va mettre les règles du jeu? Comment est-ce qu'on va préserver les intérêts publics? Parce que l'industrie, je pense, parce que j'ai travaillé toute ma vie dans le domaine de l'action aux médicaments, je pense à l'industrie pharmaceutique qui va à préserver les conflits d'intérêts qu'il peut avoir quand l'industrie pharmaceutique est impliquée dans ce type de choses. Donc là, il y a une chose à réfléchir, à mon avis. Je vois que le concept d'une santé durable a été bien développé dans beaucoup de pays, beaucoup d'organisations, mais je crois qu'il faudra penser comment est-ce qu'on passe d'une question totalement volontaire à des règles qui sont à caractère obligatoire. Et je crois que ça, c'est le sujet. Je vois compte parce que je suis de très près la négociation. Malheureusement, Precious Matoso n'est pas là, mais je suis depuis 300 de très près la négociation pour les traités contraignants, le binding treaty for the next or the future pandemic. Et il y a un problème, c'est que il y a rien de contraignant. Et les pays industrialisés refusent d'avoir des choses. Et moi, je crois qu'il y a un problème grave. S'il n'y a pas de choses contraignantes dans des mécanismes pour les mettre en place, ce qu'il y a les différents articles des traités, je crois que ça va être un échec total. Je vais vous donner un exemple que j'ai l'habitude de donner comme exemple. Si on regarde ce qui se passe depuis une trentaine d'années à l'Organisation mondiale du commerce, l'Organisation mondiale du commerce a été créée par les mêmes pays, pratiquement les mêmes pays qui sont membres de la OMS. Il y a 150 pays membres de la OMC qui ont créé la OMC il y a 30 ans. La OMC qui est chargée de réguler la circulation des marchandises. On ne parle pas de la vie humaine, on ne parle pas des droits de l'homme, des marchandises. Il faut mettre les règles, les normes pour la circulation des bananes, des cafés, des textiles. Et là, les règles sont de caractère obligatoire. Les règles de la OMS sont des règles contraignantes. Et ça, c'est très intéressant parce que même quand il s'agit du secteur privé, les règles pour une petite entreprise en Bolivie, en Cochabamba, qui fabrique des textiles, si jamais ce textile, il y a quelqu'un aux États-Unis ou en France qui vient dire le design du textile a été breveté par moi, les pays, pas l'entreprise, les pays, les autorités, l'État bolivien, il peut être mis en cause à la OMC, il peut souffrir même des sanctions économiques. Et le gouvernement bolivien, pour suivre les règles de la OMC, doit obliger à l'entreprise bolivienne d'arrêter la production. Donc, vous voyez la force des simples normes pour la circulation des marchandises. Nous, on parle de la vie humaine, on parle de l'accès à la santé, on parle de la protection de la santé, on parle d'un droit humain, parce que l'accès à la santé, c'est à la fin un droit humain. Donc je crois qu'il faut absolument, dans n'importe quel cas de figure, dans le contexte du traité, et la solution pour que les pays, parce que je vous dis, la plupart des pays en développement, qui sont les négociateurs des pays en développement, des pays du Sud, dans les traités à Genève, ils sont contre le concept de One Health, One Sustainable Health. Pourquoi? Parce qu'ils disent, si jamais on accepte et on fait les traités autour de ce concept d'une seule santé, ce qui va se passer, que ça va sortir, le traité sortira de la OMS, parce que ce n'est pas la OMS, ça serait plutôt la FAO, etc., toutes les organisations qui sont impliquées. Et là, je vais faire un petit parenthèse, parce que je crois que les pays industrialisés, la Union européenne et les États-Unis ont été très cyniques depuis une quinzaine, une vingtaine d'années avec la OMS. Ils essaient d'affaiblir au maximum la OMC. Pourquoi j'ai dit ça? Il y a une trentaine d'années, il est arrivé la pandémie de SIDA. Et qu'est-ce qui s'est passé? Jonathan Mann, le directeur du programme de SIDA à la OMS à l'époque, il a ramassé, il a été très bon pour réunir des fonds pour son programme. Il avait 100 millions de dollars. Il a rentré en conflit avec le directeur général et la solution des États-Unis, c'était sortir le programme de SIDA et on a créé une organisation. Donc, le programme de santé plus important à l'époque, on l'a sorti de la OMS. Et c'est passé après avec les programmes de vaccination de la OMS, c'était un des programmes brillants. Il y avait des taux de vaccination dans tous les pays de l'ordre de 80%. On a sorti les programmes de vaccination on a créé Gavi, l'Alliance des vaccins, où c'est un consortium public. Qu'est-ce qui s'est passé après? Il y a Brundtland qui a l'idée de créer un fonds global contre la malaria, sida, tuberculose, comme fonds, comme un mécanisme de financement de la OMS. Il y a eu un débat qui a duré pendant une année, 2 ans. Finalement, les pays industrialisés ont accepté la création du fonds global et finalement, à la dernière minute, on a sorti le fonds global de la OMS, qui est dehors de la OMS. La OMS est un simple observateur au fonds global. Qu'est-ce qui se passe après? Après, il y a l'initiative du président Lula du Brésil et Jacques Chirac de créer une agence, de créer l'unité avec la taxe qu'on donnait au billet d'avion. Et une fois que ça a été créé, on a sorti de la OMS unité qui est en dehors de la OMS. Le Covid-19 arrive. On crée les COVAX pour essayer d'assurer la vaccination pour le monde entier. Qu'est-ce qu'on fait avec les COVAX? On les sort de la OMS. Et donc, probablement le sentiment de la OMS aujourd'hui, c'est on va faire un traité international pour essayer de répondre aux possibles futures pandémies, mais donc on va les sortir parce que si c'est la FAO et si c'est les autres organisations internationales, ce ne sera pas la OMS. Donc là, il y a un problème qu'il faut voir et je crois que les pays membres de la OMS devraient à la fin voir quel va être le rôle de la OMS. Parce qu'il y a une espèce de rhétorique qui est, je m'excuse le mot, un peu hypocrite de la part des pays, surtout des pays industrialisés. Non, la OMS va coordonner. Mais comment est-ce que la OMS va coordonner? C'est les 80% de financement arrivent plutôt ailleurs. Les fonds gigantesques actuellement contre les pandémies, ils ne vont pas aller à la OMS, ils sont déjà à la Banque mondiale. Donc, comment est-ce qu'on va coordonner des organismes qui ont un budget qui est 3 fois le mien? Donc, les pauvres docteurs Tedros, ou ses représentants, ils vont comme observateurs, mais il n'y a pas de prise de décision. Je vais finir, c'était un peu trop long, je vais finir avec une simple anecdote personnelle qui est très liée à ces conflits, à ce qui se passe. Vous avez entendu parler, sûrement, probablement tous, d'un personnage important, à mon avis, qui s'appelle Jim Kim. Jim Kim, il a été le président de la Banque mondiale pendant des mandats. Mais juste avant la Banque mondiale, Jim Kim, il était à la OMS. Il était un de mes collègues. Il est arrivé à la OMS et il a créé un programme qui s'appelle les 3 by 5, les 3 par 5. Qu'est-ce que ça voulait dire? Nous étions dans l'année 2003 et la OMS, le slogan de la OMS, le programme voulait dire on va mettre 3 millions de personnes à l'année 2005. Donc, dans les prochains 2 ans, on va essayer de mettre 3 millions de personnes sur le traitement d'antirétroviraux. Si vous vous rappelez bien, les antirétroviraux à cette époque, le traitement coûtait de l'ordre de 10 000, 12 000 dollars par personne. Donc, un enfant de l'école secondaire pouvait faire la multiplication 3 millions de personnes au prix où c'était les antirétroviraux, c'était absolument impossible. Impossible. Il n'y avait pas d'argent disponible dans la communauté internationale, la UNH, les coopérations bilatérales, etc. Donc, il a été créé un groupe de travail à la OMS pour voir comment est-ce qu'on mettait en œuvre le nouveau programme de 3 by 5. Et tout d'abord, ce qu'on a fait, on n'a pas appelé, même en français, groupe de travail, on a dit une task force, parce que ça, c'est beaucoup plus à la mode et beaucoup plus fort comme expression. Et moi, je faisais partie de la task force. Et chaque fois que j'allais à la task force, on était une quinzaine de personnes. Et moi, j'ai insisté, si on veut faire vraiment les 5 personnes, 3 millions de personnes en 2 ans sur traitement, il faudra absolument parler de licences obligatoires. Il faudra absolument utiliser les droits des pays à utiliser les flexibilités de l'accord des articles, c'est-à-dire retirer les brevets et pouvoir produire des génériques. Et chaque fois, à la réunion, je disais la même chose. Jim Kim, il disait rien du tout, mais j'insistais. Et une fois à une réunion, j'ai insisté un peu fort en disant, on ne peut pas continuer comme ça, il faut absolument que des pays comme l'Inde puissent produire des antirétroviraux. Chose que vous savez tous, c'est passé quelques années après. Et c'est grâce à ça qu'aujourd'hui, il y a la plupart des Africains qui ont accès aux antirétroviraux parce que l'Inde et d'autres produits produisent ces antirétroviraux. Donc, je sors d'une réunion un peu tendue de la task force et je reçois un email de Jim King qui me dit, Herman, qu'est-ce que tu penses des licences volontaires? Quoi? Moi, je ne savais pas quoi répondre. J'ai passé une journée, 2 jours à répondre. Et un jour, ça m'est venu à l'idée, j'ai dit, je vais le répondre avec une phrase de Martin Luther King. Et la phrase dit plus ou moins, la traduction en français, ça serait, la vie, c'est une chaîne de faits qui prouvent que ceux qui ont les privilèges, ils ne l'ont jamais donné volontairement. Et j'ai envoyé l'email. La réunion suivante, je vois Jim, il ne m'a pas dit un mot sur l'email que j'avais envoyé. Et la réunion suivante, non plus, rien. Il ne m'a jamais fait un commentaire. 6 mois après, comme vous le savez probablement, Jim Kim, il quitte la OMS. Et le jour avant de s'en aller de Genève, il y a ma secrétaire qui me dit, il y a Jim King qui veut te voir. Et, mais il faut le laisser entrer tout de suite, c'est l'assistant du directeur général. Le grand lui dit, Herman, je viens te dire au revoir parce que je m'en vais demain. Je continue pas sur la Wi-Fi, je quitte la OMS et je vais te dire tout simplement que l'email que tu m'as envoyé, tu avais raison. On en a su après que Jim King, il s'est rendu compte qu'il fallait absolument ouvrir la production de génériques, autrement, on pouvait pas, il n'avait pas aucune possibilité de réussir avec l'initiative, le projet qu'il avait lancé. Bien, merci beaucoup, je m'arrête là.
Merci beaucoup, Herman Velasquez, pour votre introduction et aussi pour votre contribution. Et je pense que tu as ouvert une boîte de Pandore, et ça c'est bon, parce qu'on peut discuter un peu plus sur tous les challenges. Et, oui, ça c'est bien ouvert les débats. So I would invite the next panelists also to introduce themselves and to offer their opening statements. And once we're done with all these, and we do have some time, then I will engage you in a bunch of questions. And as I was saying, that Herman has already opened the Pandora's box beautifully, and so we can really dive in. Ultimately, what we want is to discuss potential solutions or directions for this very complicated scenario in which we find ourselves. And these are discussions which are a bit difficult to have at various levels, but in a forum like this, we can discuss these things openly. So thank you very much once again. I'd like to go right to you, Papa Sek. Papa Sek est président de Présort International Initiative. Il est ici au Sénégal, Dakar. Et il va s'introduire et puis il va aussi donner ses commentaires sur le sujet. So over to you, Papa Sek, and welcome.
Merci beaucoup, monsieur le modérateur. C'est un plaisir pour moi d'être dans ce panel sur l'approche One Health et dans le traité pandémique, qui est une problématique majeure dans le cadre de l'organisation du monde pour la bonne prise en charge de la prévention et de la surveillance des maladies émergentes et réémergentes qui pourraient vraiment menacer notre existence. Je suis là en tant que président de l'initiative internationale Présod, qui est une initiative qui a été créée en 2021 pour promouvoir les démarches préventive pour prévenir les menaces zoonotiques qui ont un potentiel pandémique. Prézode est aujourd'hui constitué de plus de 250 membres à travers le monde, où nous comptons 25 gouvernements qui sont déjà engagés dans l'initiative. Nous avons aussi, entre autres membres, des organisations internationales, des institutions de recherche, des universités et des organisations de la société civile. Prézode donc a été considéré comme partenaire important dans ce processus de négociation du traité pandémique que l'OMS est en train de conduire en ce moment. Et j'ai eu l'insigne honneur de représenter Prézode aussi au niveau de ces réunions-là. Comme vous l'avez dit, je suis docteur vétérinaire de formation de base, spécialisé en épidémiologie et en virologie. J'ai eu à travailler sur le plan international à l'Organisation mondiale de la santé animale, alors OIE, mais également pour l'Union africaine dans le cadre du programme Alive, African Livestock for Poverty Elevation and Sustainable Growth. J'ai aussi travaillé au niveau national dans la recherche, à l'Institut sénégalais de recherche agricole, et j'ai aussi travaillé au niveau le plus haut des décisions politiques au niveau national, c'est-à-dire à la primature, comme conseiller du Premier ministre du Sénégal. J'ai eu à conseiller 2 premiers ministres dans mon pays, et j'ai fini tout récemment par être conseiller du président de la République du Sénégal, surtout dans ces questions de One Health, mais également de la santé animale. Donc je suis très heureux de me retrouver parmi vous, et je vous redonne la parole en attendant de recevoir vos questions. Merci.
Merci beaucoup, Papa Sek, pour votre introduction, et c'est vraiment bon que tu as travaillé dans plusieurs sections et il y a beaucoup d'expérience. J'espère que nous serons capables de discuter un peu plus après. I'm going to go right away and invite the next panelist, and he's a scientist from the Oswaldo Cruz Foundation. It's an institution that I've grown to like very much. I've a lot of collaborators and friends in that institution. I think they have a lot to offer. And he's Riccardo Moratelli. He's a scientist, and he would introduce himself and give his initial contributions, and we'll take it from there. Over to you, Riccardo. You can, if you just.
Bonjour, merci pour votre invitation. Je ne parle pas français, je vais parler en anglais.
Oui.
I am a researcher at Fiocruz, but I am here representing one of the vice presidents of Fiocruz, the vice presidents of research and biological collections. And I work for other vice presidents, the vice presidents of environment, attention, and health promotion. So what we are talking here is an attempt of an agreement that has some 6 key points. Equity in the access to resources like medicine, vaccines, tests, and other medical products. Biological sample sharing of biological samples, that's critical for the agreement. Surveillance and monitoring, health systems resilience, research and development, and sustainable financing. And I think that One Health here, considering these key points, can contribute with the strengthening of the recognition of the interconnection between animal, environmental, and human health, with the identity and address of drivers of zoonotic diseases, mainly those with special potential pandemic, and promote joint training and education for the workforce. And part of the problems that we are discussing here to try to achieve an agreement pass through these components. So I'm trying to do as short as possible.
Thank you very much, Ricardo, for your introduction and for your initial comments. I'm going to go right away, and I'm going to invite Eschau Abanye Workina. Pardon me if I have mutilated your name, but he's the EPR project manager for the WHO, and he will give his initial introduction and contributions.
Thank you so much, Professor John, and thank you so much, the One Sustainable Health Foundation, for inviting me and then the Ethiopian WHO office to participate and share the Ethiopian experience on the One Health, and as well as the importance of pandemic treaty and also lessons from the pandemic, the COVID-19 response in Ethiopia. So I just want to highlight some few key points related with the pandemic, the One Health, and as well as the pandemic fund treaty. You know, as we already heard, starting from yesterday, about One Health and also it is important. So it is especially One Health, and the pandemic fund is a very critical, particularly for low and middle income countries, including Ethiopia. So because we were very vulnerable to the pandemics and health emergencies, and it's also worsened by limited healthcare infrastructure, and also the high human-animal environment interface are very high. And so without having or looking into the human-animal environment interface, it's very difficult to control any emergencies. So especially let's try to touch One Health and as well as pandemic treaty and how it's also work together and also interact in the context of COVID-19 response in Ethiopia. And also I directly start by, without introducing myself, my name is Aschalo Abaine. So I was working for Minister of Health Ethiopia, advisor to the minister on area of public health emergencies, and also I was Deputy Director General for Ethiopian Public Health Institute. That's one of the big public health institutes responsible for the overall public health issues in country, and as well as I was leading the public health emergencies in Ethiopia. So I was also the National Incident Manager for COVID-19 response, preparedness response, and also the recovery, especially the vaccination period. And then now I'm currently working for WHO Ethiopia Country Office, and I'm leading as a project manager for the Ethiopian Pandemic Preparedness and Response Projects that is funded by the Pandemic Fund Secretariat. That's also one of the outcome from the COVID-19 response. So One Health approach, especially in the low and middle income country like Ethiopia, it is a concept to interconnectedness of human-animal environment by health, by emphasizing that the issues arising from the zoonotic disease, such as pandemics, only effective by considering those issues, those domains together. So particularly in Africa and also part of Asia, the unique challenge is highlight importance of the One Health approach because of the high prevalence of zoonotic disease. This may be many low and middle income countries, especially in sub-Saharan Africa. It's hotspot to those zoonotic diseases where the human wildlife and it's also interaction in more common. Ebola, COVID-19, avian influenza are also being linked to the zoonotic transmission. And also the limited infrastructure and health system is one of the issue in many countries, including Ethiopia. Health systems are underfunded and understaffed, making it difficult to manage outbreak effectively. So the One Health approach aims to strengthen the collaboration across sectors, and then it's include also the public-private partnership to allow for better surveillance, early detection, and response. Again, I also commend the morning session. The one of friend from the FAO was explaining about the agricultural dependence and food security. That's also one of the issues we need to be considered for as a One Health to address the health-related issues. And the other things is environmental degradation like deforestation, urbanization, climate change, which also common in the lower and middle-income countries, and risk of transmission. So what is also the pandemic treaty and its relevance, especially in those low and middle-income countries? So the pandemic fund treaty, has been under negotiation, as my colleagues already said, and the global pandemic preparedness and response place is highly emphasized in equity, solidarity, and inclusion of key principles that resonate with the challenge faced by the low and middle-income countries and also other countries as well. The treaty aims to address some of the system issues exposed during the COVID-19 pandemics, especially around equitable access to the vaccine and resource. During COVID, in low and middle-income countries, often left behind accessing the vaccine, therapeutic and diagnostic tools. The pandemic treaty is ensured to equitable access to those critical resources in the future pandemics, and also it calls for sharing a benefited divide from the research, technology, and technology transfer, and ensuring those countries not to left behind in life-saving intervention. The other is strengthening the health systems. So the treaty highlights the need for strengthening the national health systems, especially in those low and middle-income countries in public health, enhancing the capacity for early detection, ensuring that healthcare workers are adequately trained and support. The One Health approach for this fit together here, as many of the health system improvement will also involve for better integration in animal and environmental health. So the other is international collaboration and support, because as we heard starting from yesterday, one of the issue is financing and also getting adequate fund to address this issue. So the international collaboration and support is a very critical. So the treaty stresses the international collaboration in research, data sharing, and pandemic response mechanism in low and middle income countries to benefit from this increase to support, and that would provide access to the global health sectors, security mechanism, technical assistance, and funding improvement in pandemic preparedness. So the other point in this pandemic treaty is inclusion of One Health in a pandemic planning. So by emphasizing the One Health approach, the treaty is encourages countries to integrate animal and environmental health system into their pandemic preparedness plan. It's particularly important in the low and middle income countries. So there is also a challenge, the potential challenge in both areas. So one of the challenge is the resource constraint, as I said, the financial limitation, inadequate workforce, and weak infrastructure make it difficult to implement a multi-sectoral collaboration that in One Health requires. And then the political will and the governance, because as we also heard from the discussion, to implement One Health, and also we also test this during COVID-19 response, because of the political will, because of the engagement of His Excellency the Prime Minister, and because of the engagement of all the ministers, engaging the sectors was easy, and also we use that to implement and to respond COVID timely, and also at least to minimize the fatality of the COVID-19 related diseases. So political will and the governance is one of the key issues. So the success of both One Health and the pandemic treaty depend on the strong political will, government, and intersectoral coordination, which also weaken low and middle income countries due to the political instability and competing national priorities. So the other things can be the potential problem is the data sharing issues, because pandemic treaties became now the legally binding document, so that can be an issue. So we need to also have more thorough discussion on this as well. So this is also one of the issues, because to get data from all sectors at a time to address any pandemic-related issues also, another problem. So because One Health approach is a voluntary approach, and also the sector should be voluntary and should be there, but the pandemic treaty became also the legally binding issues, so discussion and agreement should be there. So one of the critical challenge, the potential challenge also getting data, especially from surveillance. The other is dependence on the external funding source, especially both One Health initiatives and the pandemic preparedness is, especially in the low and middle income country, often rely on the external donors and international aids, which can also inconsistent or come with the specific conditions that may not be always aligned with the national priorities. So what is the way forward? So what can we do to work and to benefit from this? One is capacity building to strengthen the health workforce across human, animal, and environment is critical, especially in the rural and remote areas where the zoonotic transmission is more likely. So we need to focus specific areas, the more vulnerable community to address and to work with the community to address those issues. The other is sustainable financing, especially focusing on in domestic financing, resource mobilization, and also aligning with the sustainable, like humanitarian development nexus should be also considered in here, and also local adaptation mechanism also need to be considered. Both One Health approach and the pandemic treaty need to be adapted to local context. This involves engaging the local community, traditional healers and farmers, and public health and animal health initiatives. The other and very important point is the regional cooperation, especially in the low and the middle income countries, like particularly in Africa and Asia, can be benefit from the regional cooperation like One Health and pandemic preparedness strategy. Regional bodies like Africa CDC, the Asian Southwest Asian Health Network, and others can be play a great role. So in conclusion, I'm thinking that the One Health approach into the WHO pandemic treaty framework offers a comprehensive strategy for addressing the unique pandemic-related challenge facing by the low and middle-income countries. However, the successful implementation will be depending on the local capacity, securing sustainable funding, and fostering international and regional cooperation is also a key. Thank you so much, Mr. Chair.
Well, thank you very much, Chair, for your introduction contributions. And once again, welcome to everyone who is here, and especially those of you who are online and who are in the majority. I'd like to ask that you please submit your comments or your questions in writing. If you can type it in wherever you are following, if it's on YouTube or whatever, and we'll try and harvest these. They'll be made available, and we'll have it read out. And then if you can please state your name, your country, organization, area of specialization, and to which panelists your question is directed, or if it's general also, please let us have this. You can write in English or in French. This is acceptable. If you would like to ask a question and you are in the audience too, I think we can make that happen since there's not very many of us right here in the room. But especially for those of you online, please do write out your questions in English or in French. So all our panelists have introduced themselves and given their initial comments. And just to remind us all, we are focusing on One Health and the Pandemic Treaty. And for this reason, I'll just very briefly set the stage for the questions that I'll be posing to our panelists. I mean, where have we come from in this pandemic treaty and One Health? And as Herman rightly mentioned, One Health is, front, left, right, and center of the pandemic treaty. How did we arrive here? But you may recall that in the history of these kinds of treaties or arrangements, we really dial back to 1951, the International Sanitary Regulations. I mean, think about the name, International Sanitary Regulations. But anyway, fast forward to 2005, we had the first iteration of IHR, and the aim was really to maximize collective efforts to manage public health events, at the same time minimizing how disruptive they can be to travel and to trade. And so we had all the 196 states, parties, and compromising all the 194 WHO member states, and plus Liechtenstein and the whole EC involved in this. Now, fast forward, the next most significant such arrangement is that of December 2021, when at only the second ever, and we might have a third one, depending on how things go with these negotiations, the second ever special session of the WHA, member states launched this process to develop the world's first pandemic accord or pandemic treaty. And the aim was really to prevent what happened with COVID-19, the pandemic, the economic and social impacts thereof. And so the WHA established the INB, the Intergovernmental Negotiating Body, for which Precious Mathoso is the co-chair. Unfortunately, she was unable to stay for this and sends her regrets because of a family commitment that she had to meet back in her home country of South Africa. But they were to draft and negotiate a convention, agreement, or whatever to strengthen pandemic prevention, because it was realized that IHR was just not enough. So, fast forward, back and forth, and then through to May, June this year, WHO member states had the deadline up to pass this treaty, but then we realized that we're not there yet. We're not there at all, actually. And so it was agreed that we would continue the negotiations and put the guidelines in place before the next WHA 2025 and the next pandemic. So I like the way in which it has been put, in the sense that there is an anticipated next pandemic. There's enough evidence to show that this potential exists, and there's no reason why it will not happen. We don't wish it, but the aim is to have things in place before the next one. So let's hope that our gamble pays off and we don't get surprised before we're able to pass this. So these decisions, they represent important steps by countries, and on the final day of the 77th World Health Assembly, certain decisions were taken. And I just want to read something that Dr. Tedros, who is the WHO DG, said. He said, the amendments to the IHR will boost countries' abilities to detect and respond to future outbreaks and pandemics by strengthening their own national capabilities and coordination between fellow states on disease surveillance, information sharing, and response. This is built on commitment to equity and understanding that health threats do not recognize national borders, and that preparedness is a collective endeavor. So this is reflecting the two major decisions that we made on June 1 this year, the 77th World Health Assembly, which was to amend the IHR, and then secondly, to make concrete commitments to the negotiations and making sure that at least before the next WHA this is done, and possibly in 2024 it could be done. Now, the INB will be meeting in Geneva from November, I think, 2nd to 10th or so, but in the next 2 weeks, and we're all eagerly waiting for what the outcome of these discussions in Geneva will be. But just to highlight the main amendments in the IHR were, one, to introduce a new definition of a pandemic emergency, very critical. Second one was a commitment to solidarity and equity. This was a ground-shifting decision, because it also reflects on the pandemic treaty. And then establishment of the States Parties Committee to facilitate effective implementation of these amended regulations. And then the creation of national IHR authorities. I'm yet to know to what degree member states have been able to do the creation of these national IHR authorities. But that notwithstanding, I'm going to read to you some comments that came from two key individuals who should have been with us on this panel but couldn't. And this was at the 11th meeting of the INB, which took place just last month, between 9th and 20th of September. And as I mentioned, again, they'll be meeting from the 4th to the 15th of November in Geneva. And I read to you the comments from Ambassador Anne-Claire Ampro, who is the INB Bureau Chief Co-Chair of France. And this is what she said. She said, during extensive discussions, visible commitment was shown by member states of WHO towards a pandemic agreement. She also said there was clear recognition from all countries that we must agree on a way forward to work better together to protect their citizens and to from future pandemics. She said one more thing. She said the constructive contributions by INB relevant stakeholders were incredibly valuable. Together, we must sustain this progress towards the coming months to realize our shared goal to forge a pandemic agreement that guides future global responses to pandemics. I quote a second person, I'll end there. The Honorable Precious Matsoso, who is also the INB co-chair from South Africa, and as I said, both Ambassador Ampro and Precious Matsoso were to be on this panel but couldn't make it. She said that there was progress on fundamental areas of the draft agreement, including on research and development. This is a very important one. Regulatory systems strengthening, One Health, pandemic prevention and technology, supply chain networks, and a new system for increased access to pathogens of pandemic potential, and sharing of benefits such as vaccines, diagnostics, and treatments. And she also added, at the heart of the negotiations is recognition that collaboration among countries will ensure that the world will not be left vulnerable in the face of future pandemics, while each and every country will maintain their sovereignty and control over national health decision making. Now with that, I'm going to launch into this discussion or debate for that matter, and I would like to start with the question, how do you see the possibility of us being able to ratify or getting this draft ratified within this year, 2024, if at all before the next WHA? If you say yes, why? If you say no, why? I'll offer you 2 minutes, maximum 2.5 minutes each to respond to this. I'll start with you, Herman.
Professor, for me, the question is not if this treaty is going to be ratified now or not, in December or May. The question is what is going to be the substance and the content. Because there is a risk also that was in May this year, that the countries they can say, well, we have that, let's sign and agree on that. But if the content is very weak, nothing is going to change. You mentioned something interesting, is the reference to equity and solidarity that the developing countries managed to include in the international health regulations that were approved in this year in May. The thing, this is a very complex issue, because I don't believe that the reference in a kind of chapeau or in a sentence of solidarity and equity will solve any problem. I am very, very, very unhappy with the result of the international health regulations. If tomorrow there is a pandemic, the international health regulation, the new international health regulation, will make any difference. So the question is, and for the treaty, my question will be, if is signed in December or in May next year, I will suggest, and I will be very pleased, to replace the term of equity and solidarity. Solidarity was a total failure in the COVID. And equity is a word, is a term. I would like to include the term and the concept of justice, because justice, you have to identify mechanisms to enforce the different articles of the treaty. And you cannot request as a voluntary justice. The justice have to be enforced, and if you don't follow and enforce, in order to enforce the justice is by law, and if you don't follow the law, you are going to have sanctions. But I am more concerned about the substance than the date where it's going to be approved.
No, thank you very much, Herman, and I will come to that question on how we view the current substance and the direction in which we are going. So hold that thought. I'd like to come to you, Papa Sek, just your views on si tu pensais que ça va être ratifié dans cette année ou l'année prochaine, WT ou non. Est-ce qu'il y a la possibilité?
Merci beaucoup. En fait, j'aimerais partir à l'état actuel des négociations par rapport à la prise en compte effective de l'approche One Health dans le traité pandémique. Nous savons que à ce jour, on n'a pas d'accord sur l'inclusion de l'approche One Health dans le traité. Mais quand même, les idées convergent, les idées des pays convergent qu'il nous faut une approche holistique comme l'approche une seule santé dans le traité pandémique. Beaucoup de pays ont une réticence, mais il faut le comprendre. Parce qu'en fait, dans le traité, cette réticence-là se définit pour plusieurs raisons. Parce qu'elle est liée à la souveraineté des pays, à la répartition des ressources, à la responsabilité, mais aussi aux impacts économiques que la mise en œuvre de cette approche-là, ou bien du traité pandémique, tenant compte de l'approche One Health. Pour ce qui est de la souveraineté et de l'autonomie nationale des pays, on sait que l'intégration de l'approche exige que les pays adoptent des mesures qui impliquent souvent des secteurs au-delà de la santé humaine, traditionnellement parlant, tels que l'agriculture, la gestion de la faune et la protection de l'environnement. Et de nombreux gouvernements craignent qu'un traité international contraignant intégrant l'approche One Health ne limite leur autonomie, car il pourrait imposer des restrictions à des secteurs clés de leur économie comme l'agriculture, l'exploitation forestière ou les projets d'infrastructure. Entre autres aussi réticences, nous avons, comme je l'ai dit tantôt, la répartition des ressources et même aussi les capacités, parce qu'il faut qu'on ait des instruments qui permettent de mutualiser les ressources, de mieux les partager, mais aussi des instruments qui permettent d'aider les pays à se capaciter pour une bonne mise en œuvre de l'approche, en vue de mettre des programmes de surveillance idoine qui leur permettraient vraiment de pouvoir rendre effectif le travail. Mais aussi, comme crainte, on a des défis en matière de responsabilité de la surveillance, mais aussi de l'impact économique, surtout des préoccupations liées au développement de ces pays-là. Il faut aussi une priorisation aussi dans la réponse immédiate aux pandémies. Les pays n'ont pas tous la même priorité. Les priorités diffèrent des fois d'un pays à l'autre. Il y a des pays qui prônent pour une mise en œuvre effective d'une surveillance. Il y en a d'autres qui prônent pour une mise en œuvre plutôt d'une prévention. Et il y en a d'autres qui veulent qu'on mette en œuvre et la surveillance, mais aussi et la prévention. Donc ça veut dire en fait que les craintes sont quelque part fondées. Mais pour arriver, à mon sens, à faire accepter, d'inclure de façon engageante l'approche One Health dans le traité, il faut que ces pays-là puissent aborder une approche équilibrée dans le traité du One Health, qu'elle ne soit pas une approche vraiment contraignante. Il faut inclure un langage flexible pour permettre aux pays de les encourager à accepter l'approche, plutôt que d'imposer. Parce que quand on impose, généralement, c'est difficilement accepté. Il faut des pratiques spécifiques du One Health qu'on doit montrer comme évidence au pays, mais aussi l'objectif est de renforcer la résilience face aux pandémies sans imposer un modèle unique passe-partout, notamment pour les pays avec des contextes économiques différents et des fois difficiles. Mais in fine, nous devons accepter que l'approche One Health est un outil holistique qui nous permet de poser un mécanisme et de surveillance, mais également aussi de prévention aux éventuelles pandémie dont le monde pourrait faire face au niveau du règne animal, humain et aussi environnemental. Et pour finir, je dois dire que Présode recommande que cette approche puisse être prise en compte dans le corps du texte du traité pandémique et que ça fasse un engagement ferme et proactif de tous les acteurs en faveur des mesures de prévention primaire de l'émergence des zoonoses pour agir avant même que l'homme ne soit contaminé. En d'autres termes, cela doit inclure la mise en place de systèmes de surveillance de l'ensemble des facteurs contribuant à l'émergence des zoonoses, à la transmission de pathogènes de l'animal à l'homme et inversement de l'homme à l'animal, aussi bien au niveau nationaux que locaux. Cela demande la mise en branle de la recherche qui occupe aussi une importance capitale parce qu'il nous faut comprendre comment les pathogènes quittent l'environnement ou bien les animaux pour venir chez l'homme et vice-versa. Et aussi, il faut que nous accompagnions aussi cet engagement avec des mécanismes de financement structurants qui vont aider les pays à quelque niveau que ce soit de pouvoir établir des mesures de surveillance idoines afin barrer la route à toute menace sanitaire pouvant impacter la santé des populations et au-delà la santé mondiale. Merci.
Thank you very much for that, Papa Sek. Still, nobody has answered my question as to whether we think we can have it ratified this year or next year. But I can understand why this question is a bit challenging because it all depends on these issues being resolved. And hopefully we'll have some time to discuss these issues. But I'd like to come to you, Ricardo, just to ask you, what are your thoughts? In its current state, do you think that we can get it ratified this year or next year? And you can also dodge the question, it's allowed.
I hope so. I hope so. The Global South needs this agreement. Yeah, we need to reduce to improve the equitability. We have 4 points of content that are difficult in the agreement. And just the equitable access to vaccines and treatment. Many countries are arguing that the treaty should ensure fair and equitable access to vaccines and medicines, sustainable financing, sharing for biological samples, the creation of multilateral systems for sharing pathogens with pandemic potential is a major point of controversy. But need to solve this. And intellectual property. And I know that these are big questions to be solved before the agreement, but we need to have this solved as fast as problem because the next pandemic is on the corner probably. Yeah? We know that we expect the next pandemic from the natural world, the wildlife, and we are always talking about COVID, but if we go a little for the past, in the turn of the century we had Nipah in India and Bangladesh, in Malaysia and Singapore in 1999. 2001 we had Nipah again in India and Bangladesh in a totally different scenario from Malaysia and Singapore. Then we had SARS in China and 29 other countries. And after that, we had SARS, MERS in 2013. We had Ebola here for the first time in West Africa, vanishing Guinea, Liberia, and Sierra Leone with great impacts on health and economy. and after that, COVID, Mpox, and H5N1 for the first time in the Americas. Across the Americas, bringing some species of mammals to the brink of extinction, treating humans as well, and what's next. So we need this agreement as fast as possible.
So for Ricardo, we need it as soon as possible. We wonder when that will be, this year, next year. Okay. So let's go to you, Xiao, also for your thoughts on this. In its current state, do you think it's going to happen or not this year or next year?
Yeah, thank you so much. To decide the date, it's depending on the countries, because member states, they have their own the mandate and also their own decision. But for me, it should be this year before the next WHA, because as Ricardo already said, we all remember, because COVID is across all countries. I know why countries are debating that now the animal health issues, the environmental issues may not be a problem for the developed country. But we don't, people are forgetting the COVID-19 issues. We can remember the developed country, even the Prime Minister was also crying on the medias. I can remember because I was in daily basis in time, was following everything as a National Incident Manager for COVID-19 response. I was looking while the Italian Prime Minister was crying. So it was a very serious, while we have a good relation and we know they are very developed, and we were feeling that we don't have a system. So those who have a system, they may be protected. But the pandemic doesn't choose the economic status and other things. Now, I'm thinking that all countries, all member states should consider the inclusion of the One Health, and also other issues need to be addressed and also endorsed before the end of the year, at least to get prepared, because monkeypox is here. Because we remember when the COVID started in China, and then countries were reluctant. Some countries were prepared, others may not. They said, no, this may not come to us, because we all are here from different countries. We just arrived within a day. We don't know our status. We may come with a different kind of species with different kinds of viruses, and we are going to distribute here. And tomorrow we all are going back. We are also taking risks to our countries. That is how the virus are transmitting from one country to another country. So my final say, especially on this, the member states, as my brother Baba says, the countries are reluctant. I know some countries they send negotiators, others they didn't. Some countries they comment, the others may not. But the countries should give attention and also see things very critically and address, because at the end of the day, it is, they may not separate those countries. You may not attend the negotiation, so you are out of the rule or the law, because it can be a binding rule for every country. So the countries should take it very seriously. And also, we can't measure human life and money. So always we need to give the highest attention for human life. So because of this, I'm expecting it needs to be ratified, or it needs to be approved this year. Thank you.
Well, thank you very much for that. Papa, you wanted to say something?
Yes, if you allow me, I would like to say this. In the currently, the Article 4 and the Article 5 relating to the One Health and the Pandemic Treaty are in yellow. It means that we are not far from an agreement.
Yes.
Because as you know, in the text, the point we have in green, the meaning is we got an agreement in the point we have in green. But in the points we have in yellow, we have the ideas converge on this point. It means that since we have now the One Health issue in yellow, we can expect to have it very soon in green. I mean, to have an agreement before the end of the year. And what really we should put on the table to help countries really to converge towards an agreement in this issue is to, for me, and from preserving, is how communities are being empowered to prevent disease spillover in key countries. We have to show argument, to show way on it. And also, what kind of concrete steps are government implementing to prevent spillover? We have also to give answer to this question. And last but not least, what kind of support can member states get to implement prevention measures via One Health? This is also very key, really, to help countries to come up to an agreement before the end of the year. Thank you. Over to you.
Thank you very much, Papa. I'll come back to this question on One Health, because that will be my last question. How many more minutes? A few more minutes? 5? Okay, we'll do 5. I wanted to ask this question about, and you brought it up, Herman, about the vehicle of justice being included in the treaty. Now, because once you invoke justice, then you need to describe a mechanism by which that would be promoted. Then it also speaks to the other question of the central nature of One Health, and therefore what that means for whose responsibility it is to advance the treaty and enforce it and so on and so forth, because One Health puts the activity outside the sole remit of the WHO, and then invokes all the other bodies within the quadripartite and their responsibilities. So the question would be, this element of justice would be introducing a new layer, which is law, international law, which is another complexity. Then we already have this issue of One Health, and then who is taking the lead. If I should just ask each of you, just in a minute, to tell me, so what is the way forward, considering these two major challenges, so that we can arrive at not just a treaty that is ratified, but a treaty that has real content and the ability to make a difference. Right, so just in 1 minute, given these challenges we have unearthed very clearly, what do you suggest is the way forward in 1 minute? I'll start with you, Herman, and I'll go this way.
Professor, I don't want to frustrate you, and I will go to answer in 2 seconds your question. My prognostic, that is different than my expectations, my prognostic is that the treaty is going to be signed in December in a special worker assembly, so it's going to be to conclude in November. This is not my expectation. And my prognostic is going to be concluded without binding instruments. And the binding instruments is the way to enforce what are the decisions in order to avoid the failures that happen during the COVID-19. So the question, to enforce justice, you have to have a mechanism, instruments to enforce items, like to enforce the possibility to do access to medicines, dealing with the problem of the patents. So this is the question. Unfortunately, I don't think that the industrialized countries are going to accept the treaty with the binding instruments.
Thank you very much for that, Herman. I'll come to you, Papa, just in less than a minute if you can, because we are being waited for outside.
Yes, as everyone knows, a treaty is a legal binding, and every country should really apply it. And what really we have to to do now is how to operationalize this. And we have statutory bodies like WHO, WOHA, FAO, UNEP, etc., which are dealing with global health securities. And I think that we should give mandate of these statutory bodies to operationalize really the implementation of the One Health in this treaty. And I think country will be more confident because they know how the work is and how they should really do it from the level of from the countries to the international level. So it's really what I would like to say in this issue. And of course, we have also to think about an international or international instrument, financing instrument, has like the pandemic fund, for example, which really should be also goes to the local level. And thank you.
Thank you very much, Professor Sek. I'll go to you as Chair just for your 1 minute intervention on so what, given these two problems that we have on Earth.
Yeah, thank you so much. The straightforward answer is to implement the successful implementation. It needs the building local capacity, securing sustainable financing or funding, and fostering the international regional cooperation is critical. So who can lead this program? Because now it became, if we include One Health issues, so now it became a multi-sectoral. So one of the key things to lead in country is need to be at Prime Minister's office level to have one health or pandemic treaty secretariat or what authority to coordinate all sectors together to handle it. Because I'm bringing this from the country experience, Ethiopia. We tried to test it to have a multi-sectoral coordination led by the Deputy Prime Minister. So all sectoral ministers also under it, and then all are contributing from that. So I think this kind of coordination bring all sectors and contribute equally and implement equally, and also accountability and responsibility should be addressed. Thank you so much.
Thank you very much, as Chair. And finally, I come to you, Ricardo, for your thoughts on how we'll address these.
Yeah, if they develop a strong, sustainable financing support, we can move forward as fast as possible.
So with that, I know that we're about the last group, and so we need to close. And so thank you very much for staying with us, those of you in the room, and particularly for those of you online. Thank you very much for staying with us. And we will distill the thoughts that have come out of this discussion, and I believe they will be shared in bite-sized pieces, and hopefully we'll find their ways into various forums, other discussions, and hopefully we'll contribute to the eventual completion of this treaty process and its ratification. Thank you very much, ladies and gentlemen. Round of applause for our panelists. Thank you.